Yeah, good evening, friends. Can they hear me? Once upon a time, when William Osler used to teach, he used to teach that the inspection, palpation, auscultation, and then fourth contemplation. They are the four compass for the medical students. But today we have ECG, X-ray, echo, and angiogram as the four compasses. With the advent of echo and angio, people neglect the X-rays, but the X-rays give very good clue. Now you are seeing on your screen two X-rays are there, one to the left and one to the right. And can you make out what is the diagnosis and what is the difference? Can you tell me the diagnosis? Hello, can you tell? And okay, but what's the difference between the X-ray on the right and on the left? Tetralogy of Fallot is right. Why do you call it as tetralogy of Fallot? Yeah, oligemia with the boot-shaped heart, and in the left one, what is that? Anything else that you notice? Boot-shaped heart is right, oligemia is right. Anything else? Absent pulmonary and pulmonary bay is empty, that's fine. Okay, pulmonary bay is empty in both, that's fine. Anything else? See, I'm going to show you totally 20 quiz, and then you give 2 marks for each one of them and you decide how much you have scored. Pulmonary artery enlarged, no. No. You have to look on what side is the aortic arch. Is it on the right or the left? Because usually to do the BT shunt, you do it on the opposite side. So the X-ray gives you a clue. Okay, here the aortic arch is on to the right or to the left. No, not the tracheal stenosis. Tracheal stenosis cannot be made out. That's not the thing. Right-sided aortic arch. Not only in the right X-ray, even on the left, it is the right-sided aortic arch. What percentage of them they have the right-sided aortic arch? And in which is it common? Right-sided aortic arch is right, but what percentage? Yeah, 20 to 25% of them, they do have the right-sided aortic arch, and it is significant because the BT shunt is done on the opposite side. But of course, now we are doing the modified one, so it doesn't matter which side is the arch. Which type of tetralogy have this right-sided aortic arch? Where is it common? Okay, it's more common in pulmonary atresia. Okay, so pulmonary atresia, that's right. That's a correct one. 22q deletion, that's also right. And apart from that, what else do you see? In the left X-ray, there is oligemia. On the right side, what do you find? The oligemia is not obvious there. There's something wrong. And that child is more sick. There is a rise tube, there is a monitoring, everything is there. And if you look at the contour of the cardia, there's a bulging. You can see that. See there? There is a bulging indicating that the left ventricle is full. So where does it happen? In pulmonary atresia. In pulmonary atresia, why do you get the LV prominent? Because of the large aortopulmonary collaterals. When they have multiple aortopulmonary collaterals, the LV volume overload will be there, so the LV will be prominent. So you can see that here in this, there is the RV type. LV is not filled, but here the LV is also prominent. LV and RV. So biventricular pressures are there. And apart from that, you can see that there is a lacy appearance or the reticular appearance. And normally the pulmonary arteries branch primary, secondary, tertiary like that. But in the collaterals, it is more of a network. And that's why, you see that there is a lacy appearance or the reticular appearance that indicates that the patient has got multiple aortopulmonary collaterals. So aortopulmonary collaterals indicate that it is more in favor of the pulmonary atresia rather than the regular. So what Madam Helen Tossing, the mother of pediatric cardiology, said, cyanosis, clear lung fields, normal side heart still holds good for the diagnosis of tetralogy of Fallot. Is it clear? Okay, now and what's the difference between the two? This is the left one. You can see that the superior mediastinal widening is there in both. Okay, but there is a subtle difference between this and this. So let me know what you call this. The one on the left side. What is the diagnosis in this? The mediastinal widening. What is the diagnosis here? Okay, tell me the diagnosis in any of the two. The thymus. Thymus is not a right answer because the thymus is the structure which extends from the neck to the chest. So this shadow should have gone into the neck. Since it is not going into the neck and it is only in the chest, it cannot be thymus. Okay. So thymus is the wrong answer. So 2 marks gone. Then right one is the snowman with in the snowstorm. That is right. Supracardiac TAPVC. That's the right answer. But what is this? This is not a thymus. And this is not a supracardiac TAPVC. Because supracardiac TAPVC, you must have the plethora, what you call as the snowstorm. And the snowstorm, what you see in this, is not there. So, absent pulmonary valve is also not a right one. If there is absent pulmonary valve, at least the pulmonary artery should be seen. In fact, this is the aneurysm of arch of aorta and the descending aorta. Okay. This is the aneurysm of arch of aorta and there is no plethora. Whereas here there is a plethora and then the shadow. This is the vertical vein, horizontal vein and then the superior vena cava. And that's how this is the snowman appearance is there. And this snowman appearance, if you see, classically it is also called as figure of 8. Okay. Now, figure of 8 consists of the vertical vein and then the innominate and then the dilated SVC and of course the cardiac shadow is below. So this is the snowman in the snowstorm. Now what do you find in this? This is the newborn baby with the respiratory distress, tachypnea on monitor. What do you think? What are the things that you suspect? Okay, there is a ground glass appearance. Okay, what are the conditions where you get the ground glass appearance? One is a hyaline membrane disease. 2, pulmonary venous hypertension. Okay, pulmonary venous hypertension, right? Then infradiaphragmatic TAPVC. Okay, infradiaphragmatic TAPVC, that is obstructive, correct. So whenever you have a pulmonary venous obstruction, either due to the TAPVC or due to any other condition, you get the ground glass appearance. So ground glass appearance with distress. So remember, if the cardia is normal, it is a hyaline membrane disease. Otherwise, you must suspect the obstructed TAPVC and do an echo immediately because the mortality is very high in these patients. What do you see here? It's a 10-year-old girl. And classically, you can see that the diaphragm is higher up, and then there is a hypoplastic lung, and then this is the cardiac border, and by the paracardiac filtering, there is a paracardiac shadow. So this paracardiac shadow is the scimitar, right? That's a correct answer, Mahendra. So this is the Scimitar syndrome, the Turkish sword, and then this is the angiogram where the scimitar is nicely shown, and this is the MRI where scimitar is beautifully shown. So this is the TAPVC, partial pulmonary anomalous vein. So in this patient, you have to look for any other vessel coming elsewhere, and you must also see where the other pulmonary veins are draining. So what is the diagnosis here? Okay, what do you see here in this? And what do you see here? Any diagnosis? There is no cardiomegaly. The cardia appears normal. You had given the diagnosis earlier, and then I said it is wrong. Yeah, that is the thymus. Okay. The thymus is right. It is not the irregular shadow. It is called as a wave sign. You know, thymus is a very, very soft tissue, and which is more anteriorly placed in the neck and the chest. And as a result, the rib will make the indentation on that. And since the rib makes the indentation, you know, it gives like a wave. So that is called as a wave sign. You can see that here I'm zooming it. It is going like a wave, and this is a wave sign. So this thymus is a wave sign. And here you can see that the part of the thymus is invaginated into the horizontal fissure or the horizontal thing. So that is called as a sail sign. So either you have a wave sign because of the indentation by the ribs, or you have a sail sign when it is sitting. Now, how do you make out that this is a thymus? The cardia is normal, the patient is normal, and then you can see that this superior mediastinal widening goes right into the neck. So to call it as a thymus, the shadow has to go into the neck, one thing, and then the cardia has to be normal. So that is the correct one. So you get the 2 marks there. And now this is the 8-year-old child, bluish discoloration from birth, no history of squatting, and history of facial puffiness, swelling over the limbs, abdominal distension, and cough since 15 days, and similar episodes are occurring for the past 4 months. What do you see? There is a dilated, non-collapsing inferior vena cava. Apart from that, what do you notice? In a dilated, non-collapsing IVC, what do you see? This is the subcostal view where you are seeing the liver with the dilated hepatic veins and the inferior vena cava. Anything that you notice there? Are you able to see anything? Okay, if you are not able to make out, whenever you have a dilated, non-collapsing thing, it indicates that the pressures are very high, right-sided. So because of the stasis, you get a SEC, that is a spontaneous echo contrast. Once you have a spontaneous echo contrast, you must suspect that there is a stasis and the flow is not smooth. So whenever you have a dilated IVC, you must suspect pericardial effusion with tamponade or constrictive pericarditis, restrictive cardiomyopathy, right-sided heart dysfunction, that is the RV dysfunction, then the pulmonary artery hypertension, especially in cases of AST, the older patients, and then the RA inflow obstructions, the tumors, thrombus, or AV fistulas where the pressures are very high, or something is draining into the iotocaval fistula, draining into the right side. And apart from that, if you have a SEC in the IVC, you must think of the impaired flow with the stasis and the membrane obstruction. Now let us see what this patient has got. I'm showing you. What do you notice in this? Can you tell the diagnosis? Or at least you tell me what are the findings that you find in this. Okay, pericardial effusion with a mass, that is right. There is a large pericardial effusion, and then in the AV groove there is a large mass. So because of this mass, there is a large pericardial effusion, almost like a tamponade, and that's how the patient has got a SEC. So the SEC, the spontaneous echo contrast, gives you a clue to look for the pericardial effusion or something, and here you can make out that there is a mass, and invariably the mass in the AV grooves are epitheliomas and or other grooves, and apart from that you can see that there is a non-compaction of the ventricle. So non-compaction of the left ventricle and the pericardial effusion and the mass can only explain the failure but cannot explain the cyanosis from birth. So as a cardiologist or a pediatric cardiologist, you should not be happy with just making the diagnosis of pericardial effusion or the tamponade. You must try to look for what the other cause. Okay. So in this patient, there was a GORV which was a diagnosis causing the cyanosis, and later on the patient developed this endothelioma with the pericardial effusion. Now we move on to the next one. This is a 6 weeks neonate. Chest retractions are there, feeding difficulties, treated thing as pneumonia, severe pulmonary hypertension, and child did not improve with the treatment, and hence it was referred to the pediatric cardiologist for their opinion. So with this, what do you suspect? So I told you in the subcostal view, when you look at the dilated IVC with the SEC, you suspect pericardial effusion. But if you have a dilated IVC with the turbulence in that, a continuous flow, what do you suspect? What reversal? Nitin, what reversal are you talking about? Flow reversal in IVC, it's not a flow reversal. See, flow reversal occurs when the RA pressure is high or the tricuspid regurgitation is occurring or a tricuspid stenosis is there. But this is a neonate, yeah, correct, obstructed TAPVC, and that too from the infradiaphragmatic type. So here you can see that the veins are draining, the vein is draining into the IVC. So this is the obstructive infradiaphragmatic TAPVC. And these are the patients, as I showed you, will have the same patient. The X-ray was the ground glass appearance was there, and that gives you a clue. And the child is very sick, the hip neck. You do the echo and you see the turbulence. You look for the continuous flow, and then you look the other way. So here, what do you notice here? Once you have suspected TAPVC, what do you look for? See, the echocardiographer who had done just had given the AST, and the AST right to left chance is not a complete diagnosis. I told you the congenital heart disease, like the birds of the same feather flock together, you have the multiple problems. So here you have an AST, but what you notice is in the parasternal long axis, no pulmonary veins are draining into the LA. So LA is small, it's almost the same size or the lesser than the aorta. LA, LV are small, pulmonary veins are not draining here, but they are draining elsewhere. So let's check here. There is also a subpulmonic VST. Subpulmonic VST, small pulmonary regurgitation is there. So the complete diagnosis is congenital cyanotic heart disease with infradiaphragmatic TAPVC. AST is an obligatory shunt, and then in addition the patient has got a subpulmonic VST. So that is the complete diagnosis, and the child has to go for surgery as early as possible. So here you can make out that the continuous Doppler signals, if you get in the inferior vena cava, you must suspect and then look for the pulmonary veins where they are draining and what is happening. Okay, is that clear? So this is the figure of 8. There we saw in the X-ray figure of 8. Here we are seeing the figure of 8 in the echocardiography. Okay, so this is the vertical vein, and that's the innominate vein, and that is the IVC. And you can see that because the flow is in the different direction, this is the red and that is blue. Okay, so this is a classical figure of 8 in. Where do you see this? Supracardiac TAPVC. That's right. So you have get the full mark here. This is a supracardiac TAPVC. Okay. Sorry. Okay. This is the previous case I told you, the Monish, and the cyanosis cause is because of the DORV. You can see that the aorta and the pulmonary artery both are arising from the RV. That is the patient with the pericardial effusion and the MASH. Okay. Now, this is a 10-year-old child who presented with a blurring of vision for the past 2 years. What do you suspect? The blurring of vision in a child with this echo, and what should you look for in the eyes? Okay, I'll give you subluxation of the lens, right? In this patient had a subluxation of the lens. So the diagnosis is Marfan syndrome. Exactly, the Marfan syndrome. The child had the Marfan features, and here you can see that the aorta is dilated, the annulus is dilated, there is an aortic regurgitation. So now you have, I told you that you shouldn't be happy with just the diagnosis. You should look for the consequences and the complications, and then only you can see. So what is the commonest complication in the Marfan syndrome? This is the short axis. What do you see? Mahendra, you have given the diagnosis and the root dilatation is all right. Apart from that, what do you notice? Ascending aorta dilatation, that's fine. Anything else that you have to suspect and look for? Because this is a young child, you have to assess everything. Now look at the short cast. You see a thin layer here. Can you see that? And this is the no, not RSOV, not RSOV, no, not VST. Now I'm showing you, there are three casts, 1, 2, 3. And in the right coronary cast, there is a flap. So that is the, see, Marfan's VST is not a thing. RSOV is not a feature. What is the commonest complication? What is the commonest complication? See, you can see that there is a flap of dissection, not the prolapse RCC. That is not the prolapse. That is not the RC. That is the flap of dissection. The dissection is the commonest, especially in the older patients when they are pregnant. The dissection is the commonest complication, and you can see that the dissection is extending right up to the arch and also up to the abdominal aorta. So once the dissection has occurred, and that has to be traced right up to where it is extending, and then you have to send this patient for the MRI so that you can decide what to do. So the dissection flap is nicely seen in the short axis. Then in the suprasternal view, you have to look whether it is in the arch, and then in the abdominal, you have to look for whether the dissection is going right up to the thing. So what is the type of the dissection? See here, it is right up to the thing. So this is the true lumen and that's the false lumen. So the false lumen and the true lumen both can be made out in the abdominal aorta. So this patient has to go for the surgical correction. Okay. So apart from that, you must see whether there is a aortic regurgitation. So here you can see that there is a aortic regurgitation is also very severe. So such patients, they have to have the root thing. So what do you find here in this patient? This is a bicuspid aortic valve. Bicuspid aortic valve with the dissection flap there. Can you see that? That is the dissection flap. And this is the bicuspid aortic valve. Okay. So this is another case of Marfan's with the severe aortic regurgitation with the dissection. So now that we have finished the X-rays and echoes, we'll move on to the angios. Now, where is the catheter? What catheter is it? And what angio is it? What catheter is it? Where is it? And why the dye is injected in that? End hole catheter? No, we don't use the end hole catheter on the right side except for recording the pressure, especially the wedge pressure. Okay. So this is the main pulmonary artery. No, the main pulmonary artery will not come here. Now you see the main pulmonary artery, the catheter will enter the RA, RV, and then go to the main pulmonary artery. This is how the right pulmonary, to know what? Whether the catheter has gone through the AST into the right upper pulmonary vein, like when you go into the upper pulmonary vein like that, or it is directly draining into RA. So here the upper pulmonary vein is directly draining into RA. What are the conditions that come to your mind? So what is the diagnosis now? This is a 13-year-old patient, came with a repeated respiratory infection. The sound is cracking. Okay. I'll speak louder. Okay. Where is the catheter and what angiogram is it? The right and the left. Are you able to hear me well? Okay. So you said the main pulmonary artery. You can see that here the NIH catheter through the pulmonary artery is parked in the right pulmonary artery. So this is the selective angiogram of the right pulmonary artery. And in the liver phase, you can see that they are draining to the RA. Okay. And this is the left pulmonary artery selective angiogram. And here you can see that they are draining, the pulmonary veins are draining again to the right. So whenever you want to suspect whether it is a PAPVC or TAPVC, you have to do carefully. So here you can see that only the right upper pulmonary veins are draining into RA, whereas the left pulmonary veins are draining into LA, LV. So this is a sinus venosus type of AST, because sinus venosus type of VSTs will have 80% of them will have PAPVC. Okay. So this is the sinus venosus type of patient AST with the PAPVC. That is the right answer. Now, where is the catheter and what do you see? This patient had AST, PDA, pulmonary hypertension. Now the catheter is in the innominate vein, correct? Innominate vein, Mahendra, that is right. So what do you see when you do the hand injection? What is this? That is the LSVC, left superior vena cava. Left superior vena cava, it is not the vertical vein. Vertical vein has to be used when from the common chamber a vein is going to the left pulmonary vein, the innominate vein. But here, from the innominate vein, a vein is coming down and draining into coronary sinus. So that is the LSVC draining into the coronary sinus. Okay. So significance of LSVC draining into coronary sinus, during the closure of the AST, the surgeon will have flooding of the whole area unless there is a separate cannulation done for the left SVC also. Now, where is this catheter? That is not the vertical vein. Okay. This is the LSVC, left superior vena cava draining into coronary sinus. So the catheter from IVC, it has gone through the coronary sinus, not into RA or the RV, it is through the coronary sinus into the LSVC. Okay. And that is confirmed by the hand injection. So here the pressures will be, how do you distinguish that this is not the pulmonary artery? One, it will not go into RPA or LPA. Two, the pressure will be very low. And the three, the hand injection will show that it is draining into the thing. Okay. So that is the LSVC. And if you push, this will go right up to the neck because this is the LSVC, whereas pulmonary artery will not go. So this is how you distinguish. So in angiogram, you have to take 2 to 3 parameters. One, the saturation. to the pressure and 3 the position. So all the 3, so this is the LSVC draining into coronary sinus. So here you can see that hand injection is given, no LSVC is there, and here there is a LSVC. So LSVC draining into coronary sinus should be detected. Now what is this? If you answer this right, both of you are going to get treat for yourself, okay? Because I cannot give the treat from being so far off. TAPVC is not a right answer. TAPVC is not a right answer. Supracardiac TAPVC is also not a right answer. Correct. That's right. Mahendra, this is the LSVC draining in. So you can see that this is the dilated LSVC draining into LA, and that is the LA appendage, and then the dye is going from LA to LV. So part of it through the AST or the coronary sinus is coming to RA. So this is the LSVC draining into LA, extremely rare condition. But then here you have to distinguish between the previous one and here. There we showed the hand injection, but no opacification of the LA and appendage occurred. But here you can see that the whole LA and the LA appendage are beautifully seen, and then opacifying the LV. This is the LV. So this is the LSVC draining into LA. That's the right answer. Okay. What do you see here? See, from the IVC, it is going to the left on this side. Okay. So, friends, the anomalies of the vena cava connections, you have right superior vena cava or absent vena cava or connected to the left atrium. Okay. Or you have inferior vena cava connected and or interruption of IVC, and superior vena cava, inferior vena cava, both are connected, and that is the total anomalous systemic venous connection. So next time probably I can show you those cases, and here you can see that, see this figure of 8 in the X-ray, and then your catheter has gone through the RA, through the SVC, innominate vein, vertical vein, and down to the common chamber. So this is how the cath position will be there in the supracardiac TAPVC, and so you have to do the selective angiogram to see. You can see that anything abnormal. This is the cardiac TAPVC, cardiac type. So draining into the coronary sinus, that is intracardiac. For the surgeon, that is the easiest one to think. So where is this now? Catheter. Okay, this is the cardiac type. What do you see now? This TAPVC is draining into coronary sinus. See, this what looks like a gallbladder here is the coronary sinus. Okay. So the TAPVC can drain into superior vena cava, coronary sinus, or intracardiac thing, or in the diaphragm. So you have seen all the types. So I'll show you the rare one. This is a 11-month-old child where saturation was 72, duskiness, pericardial bulge was there, Harrison sulcus was there, and here you can see that there is a supracardiac TAPVC, and apart from that, in the same patient you see that part of it is draining into the coronary sinus. So this is the mixed type of TAPVC. So this is a 19 years old young man. You can see that when the angiogram is done, Where is it draining? Can you see that? That is the common chamber, and then it is draining here at the junction of the SVC and the RA. Okay, directly it is draining here. Rather than going through the vertical vein, innominate vein, and then coming down, it is directly draining at the junction of SVC and RA. So this is another type. So here you can see that directly the catheter has gone into the azygous system. So the types are type 1, that is 55% of them are supracardiac or vertical vein, innominate vein, and then to the SVC or to the azygous system. Type 2 are 30% of them, they drain into coronary sinus, that is the intracardiac. Type 3 are only 13% and they are in the infradiaphragmatic type, and the type 4 are only 2% and they have the mixed type. So the mixed thing, these are the ones which are very difficult to make out on the echo. So now many people make the diagnosis of TAPVC on the echo and they would like to send the patient for the surgery, but remember that will be very, very difficult to make the diagnosis if it is the mixed type, and invariably the surgeon will find it as a surprise, and hence even now the angiogram is a gold standard in these patients. Okay, so here you can see that the pulmonary veins are draining into the azygous system. So this becomes extremely difficult for you to make the diagnosis. You can suspect, but then the gold standard is angiogram, and only angiogram can tell you where it is. So this is the TAPVC with the azygous system and SVC, AST, and with the pulmonary artery hypertension. So the TAPVC to azygous, it's a very, very rare variant. Surgical importance of posing a risk to the injury, and here the operative time will be more, and the surgeon has to remove that place and then mobilize it to bring it to the LA. It becomes difficult, and so because it is at a higher level, so you have to have a accurate diagnosis. So I hope you have seen some good X-rays, good echoes, and good angios. Any questions? I hope you have learned the basics in this. Any questions? Oh, thank you so much. It's very nice of you. I hope you learned something so that Thank you, Nitin. Thank you, Mahendra. I wish more. Yeah, the Sneha is there. I didn't